the champion of football throwing. Sorry we didn't get one for you today. We'll have it for next year.
Thank you.
But he's been an educator and a true champion of safety in interventional pain. So come on up here, Dr. Candido.
Thank you, Sean. Appreciate it. Thanks to all of those of you who stayed around for the final few sessions. This is a little bit of gloom and doom, and I'm sorry about that. It's inevitable. If you practice enough, statistics must be fulfilled. And I'm going to talk about a few things. Anybody here not heard of the $60 million award recently for a lumbar transforaminal injection, which occurred in the state of New York recently? Well, I'm going to talk about that, and I'm going to ask you not to be judgmental and not to put anybody on the spot. Why are we continuing to push for the use of transforaminal injections in the lumbar spine? Now you might say, well, because they work better than interlaminar injections. And I'm going to show you some data which will easily refute that. They do not work better than lumbar epidurals performed using an interlaminar approach. So we do it for economic reasons. Let's be totally transparent. Let's be totally honest. We do transforaminal injections not because they're safer. We know they're not. Not because they're better in terms of efficacy. We can prove they're not. We do it to enhance our revenue stream. And really, if you take that approach in your practice, you may minimize and mitigate some of the things which do occur inevitably as statistics are fulfilled. Here's my title and my affiliation. I'm a director of a pain program in a Chicago hospital. I have clinical professorships in both anesthesiology and surgery at the University of Illinois College of Medicine. At the newly formed Ponce School of Medicine in Ponce, Puerto Rico, I have a professorship in surgery. I've published more than 200 peer-reviewed articles. I've written more than 100 textbook chapters. I've delivered more than 1,000 continuing medical education lectures and seminars. But that doesn't make me an expert. I've certainly made my share of mistakes in the domain of pain management. So we're going to talk about some common risks of interventional pain management procedures and techniques, talk about some strategies potentially which can help us to minimize those risks, and some alternative approaches which may be available to us. I have three sayings which are very important, and I didn't create any of them, but I live by them. One was from George Santayana. Actually, Confucius was the first person to say that those who forget the past are condemned to repeat it or relive it. It's better to be lucky than good, and good judgment comes from experience. Unfortunately, experience comes from bad judgment. If you look at the closed claims data, this was over 400,000 cases which were looked at. My good friend Jim Rathwell published this a few years ago, and they looked at 126 closed claims related to interventional pain management. And the median payment was $175,000 for cases that went to a jury trial or settlement. Improper performance of the procedure was one of the number one factors which determined an unsuccessful outcome for interventionalists. And if you look at the procedures which were cited, lumbar epidural was a majority of cases, followed by cervical epidural, followed by trigger point injections, and lastly, transforaminal injections. But transforaminal injections are notoriously very expensive cases to settle or to go to trial. Improper performance of the procedure was the number one factor determining a bad outcome. And if you look at this, the alleged outcomes was worsening of pain. What were pain management physicians? We know that our techniques can lead to worsening of pain. My informed consent, and I always amend what the lawyers produce for any institution I've ever been at. I always tell the patient, what I do now may lead to worsening of your pain condition. And I think it behooves you to look at your consent forms as they're drafted by attorneys and make the appropriate changes to them which suit your unique practice. So clinical judgment and improper performance of the procedure were the two main factors. Now, Alan Kay, another one of my dear friends from ACIP, looked at 30 years worth of data and found very similar findings from January of '88 to 2018. And here they found that the good news was that when cases go to trial, in a majority of cases, not a vast majority, 57%, the defendant, that's us, that's proceduralists, are successful in mitigating the circumstances against a medical negligence claim. The median payment here was double what we saw Rathwell paper. Instead of $175,000, it was $330,000. And the procedures that were performed in the operating room versus your clinic or versus your surgery center were more likely to lead to an award for the plaintiff, the injured patient. Procedural error was the number one factor in determining a bad outcome. The good news was for epidural steroid injections, 2/3 of the times physicians were vindicated, but the bad news was for intrathecal drug delivery systems in the 7 cases presented, in none of the cases did the physician prevail, so bad news. We're going to talk about infection, paralysis, and death. I think we'd all agree in this room that those are considered very bad outcomes, or potentially bad outcomes. Of course, we have almost a 6% infection rate with implantable devices, so it's not always bad news. And I want to talk about something which most of us who have gray hair in the audience will remember, the New England Compounding Center, the first case of fungal meningitis. Now, why do I bring this up to a talk here? Well, in 2012, we had a situation with Aspergillus fumigatus. This was the index case of fungal meningitis in this country from improperly prepared steroids in Framingham, Massachusetts by the Canigliaro family. The Canigliaro family, of course, with Daniel Canigliaro, Gregory Canigliaro, their offsprings are distant relatives of a great baseball player named Tony Canigliaro. And what people were doing were saying, well, we need steroids to be compounded. We don't want to have any preservatives in steroids. Well, why not? Noribenzine, going back to the 80s and 90s, studied polyethylene glycol. We looked at myristoyl gamma-picolinate chloride. We looked at benzyl alcohol. In the concentrations of commercially prepared steroids, there is no risk to patients. And New England Compounding Center infected a huge series of individuals across 23 states. And it occurred over a period of about a year or so. So a year after the first index case, we found a total of 751 cases. The final adjudication was about 784. And you can see the states which were represented here. Not all states, but people were buying these steroids because they had no preservatives in them. 751 total cases, 64 deaths. The final total was 68 deaths. And Michigan, Tennessee, and Indiana were the states where most of the people had infections and died. And there were not just infections. People had not just meningitis, they had paralysis, they had strokes. And of course, they had spinal serious consequences with scarring in the epidural space. So the ASRA comes forward with some of their guidelines. I think this is very useful to you. The most recent iteration was February of 2025. David Provenzano spearheaded this. I think it's important to look at what are grade A, grade B, grade C, and grade D recommendations. Grade A recommendations make sure that when you do an interventional procedure that requires antibiotics, that you administer the antibiotic preemptively at least 1 hour prior to the commencement of the procedure, that you only use drugs like vancomycin in patients who have been documented to have methicillin-resistant Staph aureus. These are grade A recommendations. That if you're going to do depilation of the hair on an individual prior to procedure, you do it in the immediacy prior to the procedure, and you use clippers, you don't use a razor. So these are the only grade A recommendations from ASRA. So what are the infections that we might encounter in our practice using implantable devices? Well, the Center for Disease Control in Atlanta, Georgia, has stipulated that there are 3 such types of infections: superficial incisional, where you have redness, heat, swelling; deep incisional, where you may have pus or an abscess; and of course, organ or space infection. That would include things like an epidural, a space-occupying lesion, or an abscess. These are the classifications according to the CDC: a superficial surgical site infection, deep surgical site infection. These are 2 of my patients who had seromas. Now, I don't know what you do in the audience here when you encounter a seroma after you place a pump or you place a stimulator. I always aspirate whatever I can. I send it to the bacteriology laboratory. I place the patient on oral antibiotics, but I don't remove the device unless I have a concern or it's constantly recurring. One patient you can see on the left side, this is a serosanguinous seroma. You can see that there is about 73 cc's I extracted on one visit. On the other side, you can see a lighter shade, but it's also a seroma of about 33 cc's. And this is not uncommon. A seroma can form. A seroma is not an indication necessarily for removing the device in my experience and in my opinion. Deeper infections, of course, require urgent care by neurosurgical colleagues and infectious disease colleagues. What are the things that increase the risks of infection? Well, for example, endogenous contamination, for example, procedures involving parts of the body which are normally considered not sterile, which is most of the body. Exogenous contamination or general immune status of the patient. The National Nosocomial Infection Surveillance Index or system rates the risks of what can lead to an infection. ASA 3 or greater is a known risk factor for high levels of infection, an operation which is classified as being contaminated. And if you're a practitioner, you need to know what the 50th and the 75th and the 25th percentile is in terms of T time for how long it takes to do a procedure. This information is available through the American Society of Regional Anesthesias and the ASA, for example. You need to know if it takes normally most people 45 minutes to place a permanent stimulator, and you're taking 2 hours, well, you're way outside the range. That leads to a higher risk of infection. So what are the 8 known factors which have been stated by the CDC to lead to an increased risk of infection? And there they are: age, classification, American Society of Anesthesiologists greater than 3, malnutrition, low serum albumin, radiotherapy, chronic steroid use. And they listed obesity and smoking. Now I have to tell you that what I'm about to discuss in the next minute or so leads to some type of academic malfeasance, unfortunately. So there's smoking and there's obesity. These are considered to be independent risk factors for infection. We studied this phenomenon, and unfortunately we posted these abstracts. We won an award for these abstracts at the American Society of Anesthesiologists national meeting several years ago. And there was a group of fellows who came from a large city in Cleveland, I won't mention it, in Ohio, called Cleveland. I won't mention the location, Cleveland Clinic. And they actually looked at what we had published here in abstract form, and they took it and wrote articles, and they preempted us, which I think is really terrible academic malfeasance, but nevertheless, it is what it is. We found that smoking and obesity did not interfere with the efficacy of spinal cord stimulators in 64 patients. We found that obesity did not affect the efficacy of stimulation, nor increase the risk of complications, including infections or lead migration. And the only thing we found of any real usefulness here was that smoking increased the risk of lead migration, but did not decrease efficacy or lead to a higher risk of infection. So these were 3 papers that we put forth in a national venue, and then somebody took that information and went back to their parent institution, which of course will not be mentioned, and they preempted us with publications. Terrible. Surgical site infections, the concerns, of course, of surgical site infections, that it leads to higher costs, higher patient morbidity, a readmission rate into the hospital or institution, and that's very, very bad, potentially. And Dr. Deere's been talking about this for more than 15 years. He's published numerous papers on this topic. Evidence and clinical experience was found to be the most important factor in minimizing or mitigating against these risks of infection. The risks of infection for total joint implants is about 2% in national surveys from our orthopedic colleagues. And for us in pain medicine for implantable stimulators and pumps, we're still at about a 4.6% rate of infection. That's a very high rate no matter what we do, which is why the ASRA guidelines should be read very carefully. And the level 1 and level 1B evidence should be adhered to vigorously, in my opinion. And there's also the process study, which showed a high rate of 8% of infections and wound breakdown for stimulation. So what are the types of things that we can do preemptively, preoperatively, intraoperatively, and postoperatively? One of the most important factors, of course, is to use chlorhexidine and alcohol. There's level 1B evidence through the CDC that that's superior to betadine. If you're using betadine for your implantables, you ought to reconsider and you ought to transition over to the use of chlorhexidine alcohol. Weight-based antibiotic use. This is a grade A recommendation from the American Society of Regional Anesthesia. What about death and interventional pain management? Unfortunately, I serve as an expert witness defending physicians all across the country, largely in my home state. I'm going to talk about a couple of cases that I was intimately integral in. Death is a very rare event, usually but not always preventable, and disproportionately expensive in terms of what these cases lead to. Now here's a case where I was an expert witness, defending an anesthesiologist in the southern part of Illinois who performed a celiac plexus block that led to the demise of the patient. And we were winning the case throughout the entirety, and the lawyers were patting me on the back. We were doing an amazing job. And then somebody pulled up a document that indicated that the proceduralist did not have privileges at the surgical center where this death occurred. So because he was performing a non-sanctioned procedure, they lost almost $8 million despite my stellar defense. Here's another case that I was integrally involved in. This is about a $3 million settlement for a cervical epidural steroid injection. I defended the proceduralist. He got out of the case. What happened was the patient had a cervical epidural steroid injection under sedation. The patient went to the recovery room, and the patient was left unattended by the anesthesia sedation provider as well as the nurse. Had a respiratory arrest. They put the endotracheal tube into the esophagus. They didn't recognize it, and the patient died. A mother of 4, a young mother, 52 years old, with 4 children. Here's another case that I was involved with, which was an anaphylactic reaction. They didn't realize the patient had an allergy to iodine, and we defended this somewhat successfully. A decision was made to settle it. The settlement was relatively modest at $350,000. I'm going to talk and finish up my discussion talking about paralysis. It's very important. I just told you about the case in New York, which led to a $60 million settlement, and there's some discrepancy or concern whether dexamethasone was utilized as the injectator, or whether it was triamcinolone. The proceduralist almost ubiquitously used triamcinolone, but for this one case, the documentation was dexamethasone. These are usually preventable. Well, then 4/23/14, the United States FDA came forth with a safety bulletin that said that we have to tell our patients that epidural injections can lead to blindness, stroke, paralysis, and death. All of you in this audience, do you tell your patients that what you're doing can lead to blindness, stroke, paralysis, and death? Interestingly, when I went back and looked at this, and we wrote several abstracts about this, the FDA utilized 17 resources to substantiate and to support this statement and this proclamation. And of the 17 articles that they utilized as reference points, 14 were exclusive to transforaminal injections. So we know that transforaminal injections can lead to a higher potential risk of blindness, stroke, paralysis, and death. And those are the 17 references. Now, how did they get there? Why do we do transforaminal injections? Well, I told you that they're reimbursed at a higher rate than interlaminar injections, but does that really matter? Well, Jim Rathmel and Steve Cohen, two noted authorities in pain management, seem to believe that transforaminal injections are somehow efficacy-wise are superior to interlaminar injections. They published this in 2013, and they indicated that the transforaminal injection was more targeted and the interlaminar injection was more generalized. Well, we went back and we looked at this. We created the concept of parasagittal interlaminar injections using a standard approach. We published our data showing no difference whatsoever whether you did a transforaminal injection or an interlaminar parasagittal technique in terms of mitigating radiculopathic pain, improving functionality, and reducing the risk of opioid consumption. And this was our premise. Our premise was that you don't have to do a midline injection. You can target it, but in the interlaminar space. Well, we weren't the only ones who looked at this. Leo Caporel, who was just here yesterday, published almost identical findings comparing interlaminar with transforaminal injections and found no difference in pain outcomes and no difference in the Oswestry Disability Index, proving, not just from my own biased opinion, but from other independent observers, that a transforaminal injection is not superior to interlaminar. We went back and looked at all the data that had ever been published on this topic. There were about 5 articles, more than 500 patients, and we did a meta-analysis and systematic review comparing interlaminar versus transforaminal injections and found no difference in pain, no clinically significant differences in efficacy for pain relief or functional improvement, whether you choose an interlaminar injection or transforaminal injection. And of course, we know that a transforaminal injection can lead to thrombosis, infarction, and of course, if it gets into the artery of Adamkiewicz, that's one thing, or the artery of Desproges-Godervon at L5S1, you can lead to an infarction of your spinal cord. That's virtually never heard of. At least I'm aware of 0 cases occurring when an interlaminar approach is utilized for a lumbar procedure. So why do we do it? Well, some would stipulate that maybe we'll be okay if we use digital subtraction angiography. And my dear colleague James Rathmel up at Harvard, he was one who said, well, you need to use DSA. Well, DSA exposes the patient and the proceduralist to 10 times the amount of radiation. It's a cine angiography. Well, we had a case at Northwestern University where an 83-year-old individual had DSA used, and he had extension tubing used, and he had a transforaminal injection at L5S1, and he ended up paralyzed, and it led to a large settlement. You can see the green arrow points to the infarction of the spinal cord at T6. So regardless of DSA use, George Chang Chen and I, George Chang Chen studied at the Cleveland Clinic. He was my resident in the Masonic Hospital in Chicago many years before that. We went back and looked at all the articles trying to find evidence that DSA was useful. Digital subtraction angiography did not indicate arterial flow, only venous flow, and therefore was not worth the expense. So, in summary and conclusions, I don't mean to tell you that you should not be using transforaminal injections, but make a choice based on clear indications. Don't make a choice based on economic considerations. Proper planning prevents poor outcome. We know that. Determine whether your patient needs a transforaminal injection. Really, if you need to use a steroid, use a soluble steroid like dexamethasone or betamethasone. We know that the efficacy is not as good as the particulate steroids. We know that they don't last as long, but patient safety is paramount to everything. These are elective procedures. Nothing that we're doing is saving the patient's life. Avoid deep sedation. Many of the cases that I've been an expert witness on had significant levels of propofol, midazolam, fentanyl. You don't need that for a 5-minute procedure. Finally, planning prevents poor outcomes. Success is patient selection. Intraoperatively, if you're doing a procedure around the spine, use chlorhexidine and alcohol. Do not use betadine. Use your antibiotic on a weight-based methodology. Hair depilation should occur in the immediacy preceding the procedure, and use a clipper, don't use a razor. Use an occlusive dressing, brief operating time, and if you have any suspicions whatsoever, send that patient immediately for an erythrocyte sedimentation rate and a C-reactive protein. Follow the patient. Don't lose sight of who's in front of you, and don't go into denial. Thank you very much. I appreciate your time and attention.
Thank you, Dr. Candido, for putting the fear of God into us. So I think a perfect way to move to the next topic is sometimes reimbursement